What would make a newly graduated nurse with perfect grades and glowing recommendations quit her dream job after just 3 shifts? In today's story, you'll discover what happened to me during my very first night as an emergency room nurse at Metropolitan General Hospital, and why the patient I encountered that October evening still makes me question everything I thought I knew about medicine and human nature. But before we dive in, hit that subscribe button to help us reach our next milestone. Drop a like if you're ready for a story that will challenge your understanding of what's possible, and let me know in the comments where you're watching from. Now settle in, because what I'm about to share with you changed the entire trajectory of my career and left me with questions I'm still trying to answer today. There are defining moments in every healthcare professional's life when they realize that textbooks and clinical rotations can never fully prepare you for the reality of patient care. Some of these moments inspire you to become a better nurse. Others leave you wondering if you're cut out for this profession at all. And then there are the rare encounters that make you question the very nature of consciousness, recovery, and what it means to truly heal someone. My name is Sarah Martinez, and I am a registered nurse with what was supposed to be a promising career in emergency medicine. I graduated summa cum laude from nursing school, completed my clinical rotations with outstanding evaluations, and had been recruited by 3 different hospitals before choosing Metropolitan General. Everything about my preparation suggested I would excel in the fast-paced, high-pressure environment of emergency care. Metropolitan General Hospital is a Level 1 trauma center serving the greater Portland metropolitan area. The emergency department sees over 90,000 patients annually, handling everything from minor injuries to life-threatening emergencies. As one of the largest teaching hospitals in the Pacific Northwest, it attracts some of the most skilled physicians and nurses in the region. I felt incredibly fortunate to have been selected for their emergency department residency program. The hospital itself is an imposing modern structure built in the early 2000s, with the emergency department located on the ground floor of the main building. The ED consists of 48 treatment rooms, arranged in 4 color-coded sections, with a central nursing station that monitors all patient activity through an advanced electronic system. The trauma bays are equipped with the latest medical technology, and the staff prides itself on their ability to handle any medical emergency that comes through those doors. My first shift was scheduled for October 22nd, a Thursday evening that began like any other day in my life. I arrived at 5:30 p.m. for the 6 p.m. to 6 a.m. shift, giving myself extra time to complete my orientation checklist and familiarize myself with the department's specific protocols. The day shift charge nurse, Linda Patterson, was a 20-year veteran of emergency nursing who had agreed to help me transition into my new role. Linda was exactly what you'd expect from an experienced ER nurse: direct, efficient, and possessing an almost supernatural ability to assess patient conditions with just a glance. She had a reputation for being tough on new nurses, but fair, and I was grateful to have her guidance during my first few shifts. The patient census that evening was typical for a Thursday night. 32 patients distributed across the treatment areas, with conditions ranging from chest pain and shortness of breath to lacerations and fractures. Linda gave me report on each patient in my assigned section, but it was when we reached room 24 that I noticed something different in her demeanor. Room 24 housed a patient who had been admitted 3 days earlier. Margaret Chen, a 67-year-old retired teacher who had been brought in by ambulance after collapsing at her neighborhood grocery store. According to her medical records, Margaret had suffered what appeared to be a severe stroke, resulting in complete loss of consciousness and minimal brain activity on neurological assessments. What made Margaret's case unusual wasn't her medical condition, but rather the series of events that had occurred during her stay in the emergency department. Linda explained that Margaret had been scheduled for transfer to the intensive care unit multiple times, but each transfer had been delayed due to what the medical staff described as equipment malfunctions and scheduling conflicts. "Linda, why hasn't she been transferred yet?" I asked, reviewing Margaret's chart. "Her condition seems stable, and she's been here for 3 days." Linda hesitated before responding. "There have been some unusual circumstances with this patient, equipment issues mostly, but also some behavioral observations that the medical team is still evaluating." "What kind of behavioral observations?" "Is exactly what makes this case so interesting," Linda replies. "Patients in Margaret's condition typically show minimal responsiveness. That Margaret shows no response to standard neurological assessments, but there have been incidents that suggest some level of awareness that we can't explain through conventional medical evaluation." Before I could ask for more details, Dr. Michael Harrison, the attending emergency physician, approached our station. Dr. Harrison was in his early 50s, with over 20 years of emergency medicine experience and a reputation for his diagnostic skills and calm demeanor under pressure. "Sarah, welcome to Metropolitan General," Dr. Harrison said. "Linda tells me you've got excellent credentials and strong clinical judgment. We're glad to have you on the team." "Thank you, Dr. Harrison. I'm excited to be here and ready to contribute however I can." "Excellent. I want to discuss Margaret Chen's case with you, since you'll be her primary nurse tonight. Her situation presents some unique challenges that I think will be valuable learning experiences for you." Dr. Harrison explained that Margaret's neurological presentation was inconsistent with typical stroke patterns. While her brain scans showed evidence of cerebrovascular damage, her physical responses didn't align with the expected deficits. More puzzling was the series of incidents that had occurred during her stay. "Dr. Harrison, what kind of incidents are we talking about?" I asked. "Margaret appears to be completely unresponsive during standard examinations, but nursing staff have reported that she seems to react to specific stimuli in ways that suggest awareness. Yesterday, Nurse Jennifer reported that Margaret's vital signs changed dramatically whenever certain topics were discussed in her presence." "What kind of topics?" "Conversations about her family, her teaching career, and particularly discussions about her discharge planning. Her heart rate and blood pressure would fluctuate in patterns that seemed intentional rather than random physiological responses." "Could these be coincidental changes related to her medical condition?" "That's what we initially thought, but the patterns are too consistent to be explained by normal physiological variation. We've documented over 30 instances where Margaret's vital signs respond to specific verbal stimuli, despite her apparent unconsciousness." Dr. Harrison continued explaining that Margaret's case had become a subject of considerable discussion among the medical staff. Her brain activity monitors showed patterns consistent with deep unconsciousness, yet her responses to environmental stimuli suggested a level of awareness that contradicted her neurological assessments. "Sarah, I want you to monitor Margaret closely tonight," Dr. Harrison instructed. "Document any changes in her condition, no matter how subtle they might seem. Pay particular attention to her responses during routine care activities, and note any patterns you observe." "Dr. Harrison, has the family been informed about these unusual responses?" "Margaret's daughter, Helen, has been here every day since her mother's admission. She's noticed some of the same things we have, and she's been asking questions about whether her mother might be more aware than we initially assessed." That evening, I began my assessment of Margaret Chen at 7:15 p.m. She was lying quietly in bed, connected to cardiac and neurological monitoring equipment, with an IV line providing hydration and medications. Her appearance was that of a woman in her late 60s, who had clearly been an active and engaged person before her medical emergency. Margaret's medical chart indicated that she had been a high school English teacher for over 40 years, retiring just 2 years earlier. She lived alone in a small apartment near the school where she had taught, and according to her daughter, she had remained actively involved in community activities and volunteer work until the day of her collapse. As I performed my initial assessment, I followed standard protocols for neurological evaluation. Margaret showed no response to verbal stimuli, no reaction to light touch, and no voluntary movement of her extremities. Her breathing was regular but shallow, and her vital signs were within normal ranges for someone in her condition. However, as I worked around her bedside, adjusting her position and checking her equipment, I began to notice subtle changes that seemed too deliberate to be coincidental. When I moved to her left side to check her IV site, her heart rate increased by approximately 10 beats per minute. When I returned to her right side, her heart rate normalized. "Margaret, can you hear me?" I asked, watching her monitors carefully. "If you can understand what I'm saying, try to change your breathing pattern." There was no obvious response, but I noticed that her respiratory rate had shifted from 16 breaths per minute to 22 breaths per minute immediately after I spoke to her. I decided to try a different approach. "Margaret, if you can hear me, I'm going to ask you some questions. You don't need to speak or move. Just let your body respond naturally." I positioned myself where I could clearly observe all her monitoring equipment. "Margaret, were you a teacher?" Within seconds, her heart rate jumped from 78 to 94 beats per minute. Her blood pressure, which had been stable at 120/70, climbed to 135/85. The changes held for approximately 30 seconds before gradually returning to baseline. "Margaret, did you teach high school English?" Again, her vital signs spiked in the same pattern. Heart rate increased, blood pressure elevated, and this time I noticed something else. Her oxygen saturation, which had been steady at 96%, briefly dropped to 92% before returning to normal. I documented these responses carefully, noting the exact times and the specific questions that triggered the changes. Over the next hour, I continued my assessment while testing different verbal stimuli. Questions about her teaching career consistently produced physiological responses, while neutral topics like the weather or hospital procedures generated no measurable changes. At 8:45 p.m., Margaret's daughter Helen arrived for her evening visit. Helen was a woman in her early 40s who clearly resembled her mother, with the same thoughtful eyes and gentle demeanor that I imagined had made Margaret an effective teacher. "Hello, I'm Sarah, your mother's nurse tonight. How are you holding up?" "It's been difficult," Helen replied. "The doctors say she can't hear us or understand what's happening, but I feel like she's still there somehow. When I talk to her about her students or her favorite books, I swear she responds." "Helen, I've been noticing some changes in your mother's vital signs that might support your observations. Would you be comfortable talking to her while I monitor her responses?" "Really? You think she might be able to hear me?" "I can't make any medical determinations, but I think it would be valuable to document what happens when you interact with her." Helen pulled a chair close to Margaret's bedside and took her mother's hand. "Mom, it's Helen. Sarah is taking good care of you tonight." Immediately, Margaret's heart rate began to climb. But this time, the increase was more dramatic than anything I had observed during my earlier assessments. Her heart rate jumped from 76 to 108 beats per minute within 15 seconds. Helen continued talking, sharing updates about family members and asking about Margaret's comfort. With each personal comment or question, Margaret's physiological responses became more pronounced. Her breathing pattern changed, her blood pressure fluctuated, and most significantly, her neurological monitors began showing activity that contradicted her supposed unconscious state. "Helen, Watch the monitors while you're talking to her, I suggested. Tell her about something specific from her teaching career. Mom, do you remember your student David Morrison? He sent me an email yesterday. He's getting married next month, and he wanted me to tell you that he's still using the writing techniques you taught him in his job as a journalist. Margaret's response was unlike anything I had seen in my clinical training. Her heart rate spiked to 115 beats per minute. Her blood pressure jumped to 150/95, and the neurological monitor began displaying brainwave patterns that suggested active cognitive processing. But what happened next challenged everything I understood about consciousness and medical assessment. Margaret's right hand, which had shown no voluntary movement since her admission, began to move in small, deliberate motions. The movements were subtle, but they appeared purposeful rather than random muscle contractions. Helen gasped and squeezed her mother's hand. Mom, are you trying to communicate with us? The hand movements became more pronounced. Margaret's fingers seemed to be tracing patterns against the bedsheet, repeating the same motions over and over. Helen watched intently, trying to decipher what her mother might be attempting to convey. Sarah, it looks like she's trying to write something, Helen said. She always graded papers by hand, even after the school went digital. Her muscle memory for writing was incredibly strong. I called Dr. Harrison to observe Margaret's responses. When he arrived, we repeated the assessment process, documenting Margaret's physiological and motor responses to various stimuli. Dr. Harrison was clearly puzzled by what he witnessed. This challenges our initial neurological assessment, Dr. Harrison admitted. Margaret's brain scans indicate significant damage that should prevent this level of responsive behavior. Yet we're seeing evidence of awareness that can't be explained by her current neurological status. Dr. Harrison, what does this mean for her treatment plan? We need to reconsider everything. If Margaret is maintaining some level of consciousness despite her apparent neurological deficits, we need to approach her care very differently. We also need to conduct additional testing to understand what's actually happening in her brain. Over the next several hours, I continued monitoring Margaret's responses while maintaining detailed documentation of every interaction. Helen remained at her mother's bedside, engaging in conversations that consistently produced measurable physiological changes. But as the night progressed, something even more extraordinary began to happen. Margaret's hand movements became increasingly coordinated. What had started as random finger motions evolved into deliberate patterns that Helen began to recognize as letter formations. By 11:30 p.m., Helen was convinced that her mother was attempting to spell out words. Sarah, she's writing the word listen, Helen said, watching her mother's finger movements carefully. She keeps repeating the same motions, and they match how she would write that word. I observed Margaret's hand movements and had to agree that they appeared to follow consistent patterns that could represent letter formation. But even more remarkable was that Margaret seemed to be responding to our conversation about her attempted communication. Margaret, if you're trying to tell us to listen, move your finger in a circle, I suggested. Margaret's response was immediate and unmistakable. Her right index finger traced a clear, circular pattern against the bedsheet, repeating the motion 3 times before stopping. Helen began crying. She can hear us. She understands everything we're saying. But Margaret's communication attempts were just the beginning of that extraordinary night. What happened next would force me to question not just medical protocols, but the very nature of consciousness itself. At midnight, Margaret's attempts at communication took a turn that left me questioning everything I thought I knew about patient care and medical assessment. What started as simple finger movements evolved into something far more complex and disturbing. Helen had been talking to her mother about former students when Margaret's hand suddenly stopped its gentle writing motions and began moving with urgent, almost frantic energy. Her fingers were no longer tracing letters, but seemed to be pointing towards specific areas of the room with deliberate precision. "Mom, what are you trying to show us?" Helen asked, following the direction of her mother's gestures. Margaret's finger pointed consistently toward the corner of the room near the window, then moved to indicate the door, then back to the corner. The pattern repeated over and over, becoming more insistent with each repetition. Her vital signs showed increasing agitation, with her heart rate climbing to 120 beats per minute. I checked the areas Margaret was indicating, seeing nothing unusual. The corner contained standard hospital equipment, a visitor chair, and medical supplies. The door was closed, and the hallway beyond was quiet except for normal hospital sounds. "Margaret, are you uncomfortable? Do you need something from those areas?" I asked. Her response was immediate, but unexpected. Instead of the physiological spikes we had been observing, Margaret's vital signs suddenly normalized. Her heart rate dropped to 80 beats per minute, her blood pressure stabilized, and her breathing became calm and regular. But her finger continued pointing with the same urgent intensity. Helen leaned closer to her mother. "Sarah, I think she's trying to warn us about something." Before I could respond, Margaret's neurological monitors began displaying patterns I had never seen in my clinical training. The brainwave activity showed sudden bursts of high-frequency activity mixed with periods of unusual synchronization across different brain regions. According to everything I had learned, these patterns shouldn't be possible given Margaret's diagnosed condition. "Dr. Harrison, I need you to come to room 24 immediately," I called through the communication system. "We're seeing some very unusual neurological activity." While waiting for Dr. Harrison, I continued documenting Margaret's responses and trying to understand what she might be attempting to communicate. Her pointing had become even more specific, focusing on a particular section of the corner where the ceiling met the wall. "Margaret, is there something in that corner that concerns you?" I asked. This time, her physiological response was unlike anything we had recorded. Her heart rate jumped to 130 beats per minute. Her blood pressure spiked to 160 over 100. And most alarming, her oxygen saturation began dropping despite adequate ventilation. "Helen, I think we should step back for a moment and let her calm down," I suggested. "Whatever she's trying to tell us seems to be causing significant stress." But Margaret's agitation only increased when we moved away from her bedside. Her hand movements became more frantic, and she began showing signs of physical distress that contradicted her supposedly unconscious state. Dr. Harrison arrived and immediately noticed Margaret's elevated vital signs and unusual neurological readings. "Sarah, what triggered this change in her condition?" "She's been trying to point out specific areas of the room, and when we acknowledge her attempts, her stress levels increase dramatically. The neurological activity patterns are unlike anything I've seen before." Dr. Harrison approached Margaret's bedside and began his own assessment. "Margaret, I'm Dr. Harrison. Can you hear me?" Margaret's response to Dr. Harrison was different from her reactions to Helen and me. Her vital signs stabilized slightly, but her pointing became more deliberate and focused. She seemed to be trying to direct his attention to the same corner of the room that had captured her focus earlier. Dr. Harrison followed Margaret's gestures and examined the area she was indicating. The corner appeared completely normal, containing only standard medical equipment and hospital furniture. But as he moved closer to investigate, something unexpected happened. "Sarah, look at the neurological monitor," Dr. Harrison called out. Margaret's brain activity had suddenly shifted to patterns that suggested active problem-solving and complex cognitive processing. The readings were consistent with someone who was not only conscious, but engaged in sophisticated mental activity. "This is medically impossible," Dr. Harrison said, studying the monitor displays. Her brain scans show damage that should prevent this level of neurological function, yet we're seeing evidence of complex cognitive activity. Dr. Harrison decided to conduct a more thorough examination of the area Margaret had been indicating. As he moved medical equipment away from the corner, Margaret's vital signs began showing patterns of anticipation and anxiety that suggested she was closely monitoring his actions. When Dr. Harrison reached behind a piece of monitoring equipment mounted on the wall, Margaret's physiological responses intensified dramatically. Her heart rate climbed to 140 beats per minute, and her neurological monitors showed activity patterns that resembled extreme alertness and concern. Dr. Harrison's hand found something unexpected behind the equipment. A small electronic device that shouldn't have been there, attached to the hospital's monitoring system with unauthorized wiring modifications. "Sarah, call security immediately," Dr. Harrison instructed, his voice tense with concern. "And contact the hospital's IT department. We have a serious security breach." Margaret's responses changed immediately when Dr. Harrison discovered the device. Her vital signs began normalizing, her agitation decreased, and for the first time since I had met her, she appeared peaceful and relaxed. Helen watched her mother's transformation with amazement. She knew something was wrong. "She's been trying to warn us about that device." The security team arrived within minutes, along with the hospital's IT specialists. The device Dr. Harrison had discovered was identified as an unauthorized monitoring system that had been intercepting and potentially manipulating patient data from multiple rooms in the emergency department. "Margaret, you've been aware of this security breach the entire time, haven't you?" Dr. Harrison asked. Margaret's response was a gentle increase in heart rate that we had learned to interpret as acknowledgement. But what happened next revealed the true extent of her awareness and the reason her case had been so puzzling to the medical staff. As the IT specialists worked to remove the unauthorized device and trace its connections, Margaret's neurological monitors began displaying patterns that suggested she was following their technical discussions and understanding the implications of what had been discovered. "Dr. Harrison, she's been conscious and aware this entire time," I realized. Her lack of response to standard assessments wasn't due to neurological damage. She was protecting herself and other patients by appearing unresponsive while she figured out how to expose the security breach. The investigation that followed revealed that the unauthorized monitoring system had been installed by someone with intimate knowledge of the hospital's electronic systems. The device was capable of accessing patient records, monitoring private conversations, and potentially manipulating treatment data. Margaret had somehow recognized the threat and had been using her apparent unconsciousness as cover while she attempted to alert the medical staff to the danger. Her unusual responses to neurological assessments, her selective communication attempts, and her persistent efforts to direct attention to the hidden device were all part of an elaborate strategy to expose the security breach without alerting whoever had installed the monitoring system. Over the next hour, as the unauthorized device was removed and the security investigation began, Margaret's condition underwent a remarkable transformation. Her neurological assessments began showing normal patterns of consciousness and cognitive function. Her responses to verbal stimuli became appropriate and consistent. Dr. Harrison conducted a comprehensive neurological examination and found that Margaret's brain function was significantly better than her initial scans had suggested. While she had suffered some damage from her original stroke, her cognitive abilities and awareness had been largely preserved. "Margaret, can you speak to us now?" Dr. Harrison asked. Margaret opened her eyes for the first time since her admission and looked directly at her daughter. "Helen, I've been trying to protect you and the other patients. Someone was watching and listening to everything that happened in these rooms. The medical team was stunned by Margaret's clear speech and obvious cognitive function. Her ability to maintain apparent unconsciousness while remaining fully aware and actively working to solve a complex problem demonstrated a level of mental discipline and strategic thinking that challenged our understanding of stroke recovery and consciousness. Helen, I heard every conversation you had with me. I knew you were worried, but I couldn't respond normally because I realized someone was monitoring everything. I had to find a way to expose the threat without putting anyone in danger. Margaret's case became the subject of intensive medical and security investigations. The unauthorized monitoring device was traced to a former hospital employee who had been stealing patient information and selling it to identity theft networks. Margaret's persistent attempts to alert the medical staff had prevented further security breaches and protected countless patients from privacy violations and potential fraud. But Margaret's story raised profound questions about consciousness, medical assessment, and the capabilities of patients who appear to be unresponsive. Her ability to maintain strategic thinking while simulating unconsciousness suggested that human awareness might be far more complex and resilient than standard medical protocols recognize. Dr. Harrison, how many other patients might be more aware than we realize? I asked as we completed Margaret's reassessment. That's exactly what keeps me awake at night now, he replied. Margaret's case suggests that consciousness might persist in ways that our current diagnostic methods can't detect. We might be underestimating patient awareness more frequently than we realize. Margaret's recovery proceeded rapidly once the security threat was eliminated and she could safely resume normal responsiveness. Within 48 hours, she was transferred to a regular medical floor and began participating in standard rehabilitation therapy. Her stroke had caused some physical limitations, but her cognitive function remained sharp, and her strategic thinking abilities were clearly intact. The investigation into the security breach revealed that Margaret had recognized the unauthorized device during her first day in the emergency department. Her background as a teacher had included supervising student computer labs, giving her enough technical knowledge to identify equipment that didn't belong in a medical setting. Rather than attempting to communicate her concerns immediately, Margaret had made the strategic decision to appear unconscious while she observed the device's operation and attempted to determine who might be responsible for installing it. Her apparent lack of responsiveness had been a deliberate protective strategy designed to keep her safe while she gathered information and found a way to alert the medical staff. Margaret later explained that she had been fully conscious throughout her stay, but had recognized that normal communication might put her and other patients at risk if someone was indeed monitoring patient interactions. Her selective responses to specific stimuli had been carefully calculated attempts to guide the medical staff toward discovering the security breach without directly revealing her awareness to potential surveillance. The case of Margaret Chen fundamentally changed how I approached patient assessment and care. Her experience demonstrated that consciousness and awareness might exist in forms that standard medical evaluation doesn't recognize, and that patients might be capable of complex strategic thinking, even when they appear to be neurologically compromised. As my first shift at Metropolitan General came to an end, I realized that Margaret's case had taught me more about nursing, patient advocacy, and human resilience than all my years of education and training combined. Her courage in maintaining her protective strategy while working to expose a serious security threat exemplified the kind of strength and intelligence that patients bring to their own care, even in the most challenging circumstances. But Margaret's story also left me with unsettling questions about how many other patients might be experiencing levels of awareness that go unrecognized by medical teams. Her case suggested that the boundary between consciousness and unconsciousness might be far more complex than our diagnostic tools can measure, and that patients might be capable of sophisticated reasoning and strategic behavior, even when they appear to be unresponsive. The implications of Margaret's case extended far beyond what happened in room 24 that night. As I completed my documentation and prepared to leave Metropolitan General at the end of my shift, I couldn't stop thinking about the dozens of seemingly unresponsive patients I had encountered during my clinical rotations. How many of them had been fully aware, listening to every conversation, understanding every medical discussion about their condition, but unable to communicate their consciousness in ways our protocols could recognize. Dr. Harrison pulled me aside as I was gathering my belongings. "Sarah, I want you to know that what happened tonight represents the kind of nursing observation and advocacy that saves lives. Your attention to Margaret's subtle responses and your willingness to document patterns that seemed unusual made all the difference in uncovering this security breach. Thank you, Dr. Harrison. But honestly, I feel like Margaret did all the work. She was the one who recognized the threat and found a way to protect everyone despite her physical limitations. That's exactly my point. You recognized that her responses meant something significant, even when they didn't fit standard neurological assessment patterns. That kind of clinical judgment can't be taught in textbooks. But as the days passed and I continued working at Metropolitan General, Margaret's case began affecting how I interacted with every patient. I found myself paying attention to subtle changes in vital signs that I might have previously dismissed as normal physiological variation. I started talking to unconscious patients differently, explaining procedures more thoroughly, and watching for responses that might indicate awareness. More disturbing was the realization that Margaret's strategic thinking during her apparent unconsciousness suggested capabilities that challenged fundamental assumptions about patient care and medical decision-making. If patients could maintain complex cognitive function while appearing neurologically compromised, what did that mean about informed consent, treatment discussions, and the privacy of medical conversations conducted in their presence? Margaret Chen's story haunts me because it revealed how much we still don't understand about consciousness and patient awareness. 3 months after that night, I made the difficult decision to leave emergency nursing. Not because I doubted my abilities, but because I couldn't shake the feeling that every unconscious patient might be fully aware, trapped in silence, waiting for someone to notice the subtle signs that their mind was still fighting. Margaret taught me that the most important part of nursing isn't following protocols or monitoring equipment. It's listening to what patients are trying to tell us, even when they can't speak. Her courage in protecting others while appearing helpless reminds me why I became a nurse in the first place. And her case continues to influence how I approach patient care in my current role. If you've ever wondered whether unconscious patients can hear you, talk to them anyway. You never know who might be listening, planning, and waiting for someone to truly see them.